that cancer cells do. But because some cancers, carcinomas in situ, may become cancer, they are usually treated. This is an illustration of a normal hypoplastic dysplastic cancer cell, right? So normal cells may become cancer cells before cancer cells form in tissues of the body. The cells go through abnormal changes called hyperplasia and dysplasia. In hyperplasia, there is an increase in the number of cells in an organ or tissue that appear abnormal under a microscope. In dysplasia, the cells look abnormal under a microscope but are not cancer. Hyperplasia and dysplasia may or may not become cancer. Credit at Therese Winslow. Thank you. Types of cancer. There are more than 100 types of cancer. Types of cancers are usually named for the origins or tissues where the cancers form. For example, lung cancer starts in the lung and brain cancer starts in the brain. Cancers may also be described by the type of cells that formed them, such as epithelial cells or squamous cells. You can search NCI's website for information on specific types of cancer based on the cancer's location in the body or by using A to Z list of cancers. We may also have information on childhood and cancers in adolescents and young adults. This lecture will be over in a couple of minutes from now. That will be a continuation of the same subject in the next lecture. So do stay tuned and I continue to talk on the subject. As it closes down, the next section will be there. Please follow those lectures too to get a continuity of the subject, right? So we're continuing. Here are some categories of cancer that begin in specific types of cells. So carcinoma, right, are the most common type of cancer. They are formed by epithelial cells, which are cells that cover the inside and outside surface of the body. There are many types of cells which often have a column-like shape when viewed under a microscope. Carcinomas that begin in different epithelial cell types have specific names. You have adenocarcinomas, basal cell carcinoma, squamous cell carcinoma, transitional cell carcinoma. You have sarcomas, where you call the osteosarcoma, and leukemias, and lymphomas, multiple myelomas, and melanomas, etc. will come in the next lecture. All details, brain and spinal called tumors. Other types of tumors, germ cell tumors, neuroendocrine tumors, carcinoid tumors, and related resources. I'll see you in the next lecture a few minutes from now, right? So please stay tuned, make notes, and be well informed, right? And we'll see you there. In the meanwhile, I'll just finish a couple of seconds of talk on the same carcinomas. Now, adenocarcinoma is a cancer that forms in epithelial cells that produce fluids or mucus. Tissues with this type of epithelial cells are sometimes called glandular tissues. Most cancers of the breast, colon, and prostate are adenocarcinomas, right? And basal cell carcinoma is a cancer that begins in the lower basal or base layer of the epidermis, which is a person's outer layer of skin. That being said, we have another kind called squamous cell carcinoma, which is a cancer that forms in squamous cells, which are epithelial cells that are just lie beneath the outer surface of the skin. And squamous cells also line many other organs, including stomach, intestines, lungs, bladder, and kidneys. And squamous cells look flat like fish scales when viewed under a microscope. Squamous cell carcinoma is sometimes called epidermoid carcinomas. Okay, this and more, and about transitional cell carcinoma in the next is a cancer that forms type of epithelial tissue called transitional epithelium or uroepithelium. It's made of many layers of epithelial cells that get bigger and smaller. It's found in linings of the bladder, ureter, parts of the kidneys, renal, pelvis, and few other organs. Some cancers of bladders, ureters, and kidneys are transitional cell carcinomas. I'll see you in the next lecture. Thank you. Right, and continuing from where we left, sarcomas. They are cancers that form in bone and soft tissues, including muscle, fat, blood vessels, lymph vessels, and fibrous tissues such as tendons and ligaments. Osteosarcoma is the most common cancer of bone. The most common type of soft tissue sarcoma are leiomyosarcoma, leiomyosarcoma, that's a correction there. Kaposi sarcoma, malignant fibrous histiocytoma, liposarcoma, and dermatofibrosarcoma and protuberance. Dermatofibrosarcoma, protuberance. The page on soft tissue sarcoma has more information, so here we go on soft tissue sarcomas. Soft tissue sarcoma, patient version. Overview. Soft tissue sarcoma is a broad term for cancers that start in soft tissues. Muscle tendons, fat, lymph and blood vessels, and nerves. These cancers can develop anywhere in the body, but are found mostly in the arms, legs, chest, and abdomen. Explore the links. Let's explore the links on this page to learn more about different types of soft tissue sarcoma and how they are treated, and with the information on research and clinical trials. Now the treatment part, PTK treatment information patient is soft tissue sarcoma treatment, gastrointestinal stromal tumors treatment, childhood gastrointestinal stromal tumors treatment, and then Kaposi sarcoma treatment, childhood rhabdomyosarcoma sarcoma treatment, childhood soft tissue sarcoma treatment, and childhood vascular tumors treatment and related aspects. See the causes and prevention and screening. Right, and continuing with the various types of cancers. Now with the next one will be leukemia. Once we get under the headings and just the basic details, we then go in for the details. Okay, after the basic details, we go in for advanced details of each type of cancer. Okay, the next basic type of cancer seen is leukemia. Cancers that begin in the blood-forming tissue of the bone marrow are called leukemia. These cancers do not form solid tumors. Instead, large numbers of abnormal white blood cells, leukemia cells, and leukemic blast cells build up in the blood and bone marrow, crowding out normal blood cells. The low level of normal blood cells can make it harder for the body to get oxygen to its tissues, control bleeding, or fight infections. There are 4 common types of leukemias, which are grouped based on how quickly the disease gets worse, acute or chronic, and on the type of blood cell the cancer starts in, lymphoblastic or myeloid. Acute forms of leukemia grow quickly and chronic forms grow more slowly. And there are 4 common types of leukemia, which are grouped based on how quickly the disease gets worse, acute or chronic, and on the type of blood cell the cancer starts in, lymphoblastic or myeloid. Acute forms of leukemia grow quickly and chronic forms grow more slowly. The page on leukemia has more information. We'll get to that later. Next will be lymphoma. Lymphomas is a cancer that begins in the lymphocytes T cells or B cells. These are disease-fighting white blood cells that are part of the immune system. In lymphoma, abnormal lymphocytes build up in lymph nodes and lymph vessels as well as in other organs of the body. There are 2 main types of lymphomas, Hodgkin's lymphoma and non-Hodgkin's lymphoma. People with this disease have abnormal lymphocytes that are called Reed-Sternberg cells, and these cells usually form from B cells. Non-Hodgkin's lymphoma, this is a large group of cancers that start in lymphocytes. The cancers can grow quickly or slowly and can form from beta cells or T cells. Next will be multiple myeloma, which is a cancer that begins in plasma cells, another type of immune cell. The abnormal plasma cells, called myeloma cells, build up in the bone marrow and form tumors in bones all through the body. Multiple myeloma is also called plasma cell myeloma and Calor disease. Melanoma is the next one. It's a cancer that begins in cells that become melanocytes, which are specialized cells and that make melanin, the pigment that gives skin its color. Most melanomas form on the skin, but melanomas can also form in other pigmented tissues such as the eye. The next would be brain and spinal cord tumors. These are different types of brain and spinal cord tumors. These tumors are named based on the type of cell on which they formed and where the tumor first formed in the central nervous system. And for example, an astrocytic tumor begins its star-shaped brain cells called astrocytes, which help keep nerve cells healthy. Brain tumors can be benign, not cancer, or malignant cancer. The other types of tumors are germ cell tumors, which are a type of tumor that begins in the cells that give rise to sperm or eggs. These tumors can occur almost anywhere in the body and can be either benign or malignant. And neuroendocrine tumors are formed from cells that release hormones into the blood in response to a signal from the nervous system. From the nervous system, these tumors, which may make higher than normal amounts of hormones, can cause many different symptoms. Neuroendocrine tumors may be benign or malignant. Carcinoma tumors are a type of endocrine tumor. They are slow-growing tumors that are usually found in the gastrointestinal system, most often in the rectum and small intestine. Carcinoma tumors may spread to the liver or any other site in the body, and they may secrete substances such as serotonin or prostaglandins, causing carcinoid syndrome. The other tumors are on gastrointestinal neuroendocrine tumors that have more information. And related results would be tumor-grade pathology reports, metastatic cancer when cancer spreads, and common cancer myths and misconceptions. Right? Now, we're going to the tumor grade. Tumor grade describes how normal or abnormal cancers look under a microscope. The more normal the cells look, the less aggressive the cancer and more slowly it grows and spreads. On the other hand, the more abnormal the cells look, the more aggressive the cancer and faster it is likely to grow and spread. Tumor grade is not the same thing as cancer stage. Stage refers to how large a cancer tumor is and how far the cancer has spread. We can see cancer staging in relation to this. Right. Cancer staging. Stage refers to the extent of your cancer, such as how large the tumor is and if it is spread. Knowing the stage of your cancer helps your doctor understand how serious your cancer is and your chances of survival. Plan the best treatment for you. Identify clinical trials that may be treatment options for you. A cancer is always referred to by the stage it was given at diagnosis. Even if it gets worse or spreads, new information about how cancer has changed over time is added to the original stage, so the stage doesn't change even though cancer might. How staging is done, how stage is determined. To learn the stage of your disease, your doctor may order x-rays, lab tests, and other tests or procedures. We need to refer the section on how cancer is diagnosed to learn more about these tests. Right? And let's go to that as well. Now, how cancer is diagnosed. If you have a symptom or a screening test result that suggests cancer, your doctor will find out whether it is due to cancer or some other cause. There is no single test that can diagnose cancer. So the doctor will start by asking about your personal and family medical history and doing a physical exam. They may order lab tests, image test scans, or other tests or procedures. They may also need a biopsy, which is often the only way to tell for sure if you have cancer. Now, this page covers tests that are often used to help diagnose cancer depending on the symptoms. One may have to have other tests too. To learn more about how specific cancer are diagnosed, we need to refer the PDQ cancer treatment summaries for adult and childhood cancers. These summaries include detailed information about the picture diagnostic tests and procedures for a specific type of cancer. So we also have making sense of test results, lab tests used to diagnose cancer, imaging tests used in cancer, biopsy, and what happens to tests if it shows that you have cancer. Or making sense of the results and lab tests used to diagnose cancer. Right, the blood chemistry test, how it's done, the complete blood cell count, how it's used, cytogenetic analysis, immunophenotyping, liquid biopsy, sputum cytology, tumor marker tests, urine analysis, urine cytology, imaging tests used in cancer, CT scan, MRI, nuclear scan, a bone scan, a PET scan, an ultrasound, X-rays, biopsy with a needle, with endoscopy, colonoscopy, bronchoscopy. With surgery, some biopsies may require sedative anesthesia, local anesthesia, or regional anesthesia, or a general anesthesia. Right? These are the sections we need to have in detail, but we'll come to these a little later. What happens if tests show you have cancer? And then you have the related resources on that. There's a biomarker testing for cancer treatment, pathology reports, tumor markers, sentinel lymph node biopsy, FDA approves blood tests that can help guide cancer treatment, FDA approved tests. Now let's go back and we're onto how the cancer staging is done. So the stage refers to the extent of a cancer, such as how large the tumor is and if it has spread. Knowing the stage of a cancer helps your doctor. So that we've just read on that those details. Now how stage is determined. Before that we just gone on to the next page, right? Just to see the clinical trials and all those things. And to cancer always refer to about the diagnosis and all these things. So now, how cancer is diagnosed is where we went. Now we're back to systems that describe stage. There are many staging systems. Some such as the TNM staging system are used for many types of cancer. Others are specific to a particular type of cancer. Most staging systems include information about where the tumor is located in the body, size of the tumor, whether cancer is spread to nearby lymph nodes, whether the cancer has spread to a different part of the body. The TNM staging system. The TNM system is the most widely used cancer staging system. Most hospitals and medical centers use the TNM system as their main method for cancer reporting. One is likely to see cancer described by the staging system in the pathology report, unless there is a different staging system for the type of cancer. Examples of cancers with different staging systems include brain and spinal cord tumors and blood cancers. The TNM system, the T refers to the size and extent of the main tumor. This is a very important aspect of cancer staging. Right? So note these points down. And the main tumor is usually called the primary tumor. The N refers to the number of nearby lymph nodes that have cancer. The M refers to whether the cancer has metastasized, which means that the cancer has spread from primary tumor to other parts of the body. Whether your cancer is described by the TNM system, there will be numbers after each letter that give more details about the cancer. For example, T1N0MX or T3N1MO. The following explains what the letters and the numbers mean. Primary tumor, T. X, main tumor cannot be measured. T0, main tumor cannot be found. T1, T2, T3, T4 refers to size and or extent of the main tumor. The higher the number after the T, the larger the tumor or the more it has grown into nearby tissues. T's may further divide to provide more details such as T3A and T3B. Renal lymph nodes. NX is lymph node cannot be measured. N0 there is no lymph node involved. N1, N2, and N3 refers to the number and location of lymph nodes that contain cancer. The higher the number after the N, the more the lymph nodes that contain cancer. Distant metastasis M. MX cannot be measured. M0 has not spread to other parts of the body. M1 cancer has spread to other parts of the body. So other ways to describe stage. TNM system helps describe cancer in great detail, but for many cancers, the TNM combinations are grouped into 5 less detailed stages. The following chart shows how your doctor or nurse may describe your cancer stage and what it means. Stage 0. Abnormal cells are present but have not spread to nearby tissues, also called carcinoma in situ or CRS. CRS is not cancer, but it may become cancer. Possible. We wouldn't want to use the word precancer too, because it is yet to even become malignant sometimes. So it's just a start of like hyperplasia, things like what we read. Could become, right? And stage 1, stage 2, and stage 3 may also be written as stage 1, stage 2, and stage 3. cancer is present, the higher the number, the larger the cancer tumor, and the more it is spread into nearby tissues. Stage 4 may also be written as stage 4, numerals and in Roman letters. The cancer is spread to distant parts of the body. The higher the number, the more advanced the cancer is. Letters and numbers are often used after the first number to describe the cancer in more details. For instance, stage 2 prostate cancer may be further divided into 2A, 2B, and 2C. Another staging system that is used for all types of cancer groups cancer into one of 5 main categories. The staging system is more often used by cancer registries than by doctors, but one may still hear the doctor and nurse prescribe the cancer in one of the following ways: in situ, which means abnormal cells are present but have not spread to the nearby tissues. Localized, this cancer is limited to the place where it started with no sign that it is spread. Regional, as it has spread to nearby lymph nodes, tissues, or organs. Distant, as cancer is spread to distant parts of the body. And unknown, as there's not enough information to figure out the stage. To know more about the types of cancer, we need to visit the PDQ cancer treatment summaries for adult and childhood cancers. Right. The next would be about pathology reports. So we need to know in pathology reports, what is a pathology report? How is tissue obtained for examination by pathologists? How does a pathologist examine tissues? What is the gross description on a surgical pathology report? What is a microscopic description on a surgical pathology report? What is the diagnosis on a surgical pathology report? Are molecular characteristics of a tumor included on a surgical pathology report? What are the information might be included on a surgical pathology report? How will I find out what is my surgical pathology report? Can individuals get a second opinion on other surgical pathology results? Right? So what is a pathology report? Pathology report, sometimes called a surgical pathology report, is a medical report that describes the characteristics of a tissue specimen that is taken from a patient. The pathology report is written by a pathologist, a doctor who is a specialist training in identifying diseases by studying cells and tissues under a microscope. The pathology report includes identifying information such as the patient's name, birth date, and biopsy dates, and details about where in the body the specimen is from and how it was obtained. It typically includes a gross description, a visual description of the specimen as seen by the naked eye, a microscopic description, and a final diagnosis. It may also include a section for comments by the pathologist. The pathology report. The pathology that it provides, the definitive cancer diagnosis. It's also used for staging, describing the extent of cancer within the body, especially whether it has spread, and to help plan treatment. Common terms that may appear on a cancer pathology report include invasive, non-invasive, in situ, carcinoma, benign neoplasm, malignant, adenocarcinoma, margin, infiltrating, ductal, undifferentiated, and or well differentiated. How is tissue obtained for examination by a pathologist? Where the pathologist examines cells or tissues obtained during a biopsy, which is a procedure to remove a cell or tissue specimen for examination by a pathologist, or surgery, or from bodily fluids. The biopsy specimen can be obtained in several ways, such as by taking a tissue sample from the surface of the skin, using a needle inserted through the skin to withdraw tissue or fluid, inserting a thin, lighted tube called an endoscope through the mouth, anus, urethra, or a small incision in the skin to look at areas inside the body, to remove a sample using special tools that pass through the tube. If surgery is required to remove part or all of a tumor, some or all of the removed tumor specimen will be examined by the pathologist. If the entire tumor is removed, typically a surgeon will attempt to remove some normal tissue around the tumor known as the margin for examination by the pathologist to make sure it doesn't contain tumor cells. For some cancer types, especially breast cancer and melanoma, the surgeon may also remove nearby lymph nodes called the sentinel lymph nodes. So the pathologist can see if these contain cancer cells. The sentinel lymph node biopsy factually describes this procedure and is used in describing the extent or stage of cancer in the body. Let's see that. The pathologist is asked for sentinel lymph node biopsy. So it requires for us to know what are lymph nodes, what is a sentinel lymph node, what is a sentinel lymph node biopsy. Excuse me. What happens during an SLNB, sentinel lymph node biopsy, right? What are the benefits of SLNB? What are the possible harms of SLNB? Is SLNB used to help stage all types of cancer? What has research shown about the use of SLNB in breast cancer? What has research shown about the use of SLNB in melanoma? What are lymph nodes? Well, the lymph nodes are small round organs that are part of the body's lymphatic system. The lymphatic system is a part of the immune system. It consists of a network of vessels and organs that contain lymph, a clear fluid that carries infection-fighting white blood cells, as well as fluid and waste products from the body's cells and tissues. In a person with cancer, lymph can also carry cancer cells that are broken off from the main tumor. This is a picture of the lymph nodes. Take a good note. Anatomy of the lymphatic system, showing the lymph vessels and lymphatic organs including lymph nodes, tonsils, thymus, spleen, and bone marrow. And the top insert shows the structure of a lymph node and the lymph vessels, with arrows showing how lymph and immune cells, called lymphocytes, move into and out of the lymph node. Bottom insert shows a close-up of the bone marrow. This is work by NIC, credit to Teresa Winslow. Lymph is filtered through lymph nodes, which are found widely throughout the body and are connected to one another by lymph node vessels. Groups of lymph nodes are located in the neck, underarms, chest, abdomen, and groin. The lymph nodes contain what you call lymph is filtered through lymph nodes, which are found widely throughout the body and are connected to another by lymph vessels. Groups of lymph nodes are located in the neck, arms, chest, abdomen, and groin, as we just read. The lymph nodes contain white blood cells, B lymphocytes, and T lymphocytes, and other types of immune system cells. Lymph nodes trap bacteria and virus, as well as some damaged and abnormal cells, helping the immune system fight disease. Many types of cancer spread throughout the lymphatic system, and one of the earliest sites of spread for these cancers is nearby lymph nodes. So what is a sentinel lymph node? A sentinel lymph node is defined as the first lymph node to which cancer cells are most likely to spread from a primary tumor. Sometimes there can be more than one sentinel lymph node. So what is a sentinel lymph node biopsy? Well, sentinel lymph node biopsy is a procedure in which the sentinel lymph node is identified, removed, and examined to determine whether cancer cells are present. And it is used in people who have already been diagnosed with cancer. A negative SLNB result suggests that cancer has not yet spread to nearby lymph nodes or other organs. A positive SLNB result indicates that cancer is present in the sentinel lymph node and that it may have spread to other nearby lymph nodes called regional lymph nodes and possibly other organs. This information can help a doctor determine the stage of the cancer, extent of the disease within the body, and develop an appropriate treatment plan. So what happens during an SLNB? First, the sentinel lymph node or nodes must be located. To do so, a surgeon injects a radioactive substance, a blue dye, or both near the tumor. The surgeon then uses a device to detect lymph nodes that contain radioactive substance or looks for lymph nodes that are stained with the blue dye. Once a sentinel lymph node is located, the surgeon takes a small incision, makes a small incision in the overlying skin and removes the node. The sentinel node is then checked for the presence of cancer cells by a pathologist. If cancer is found, the surgeon may remove additional lymph nodes, either during the same biopsy procedure or during a follow-up surgical procedure. SLNB may be done on an outpatient basis or may require a short stay in a hospital. SLNB is usually done at the same time during the primary tumor is removed. In some cases, the procedure can also be done before or even after, depending on how much the lymphatic vessels have been disrupted. Removal of the tumor. During removal of the tumor. So what are the benefits of SLNB? The SLNB helps doctors stage cancers and estimate the risks that the tumor cells have developed. The ability to spread to other parts of the body. If the sentinel node is negative for cancer, a patient may be able to avoid more extensive lymph node or surgery, reducing the potential complications associated with having many lymph nodes removed. What are the possible harms of SLNB? All surgery to remove lymph nodes, include SLNB, can have harmful side effects, although removal of fewer lymph nodes is usually associated with fewer side effects, particularly serious ones such as lymphedema. The potential side effects include lymphedema or tissue swelling during lymph node surgery, lymph vessels leading to and from the sentinel node or group of nodes are cut. This disrupts the normal flow of lymph through the affected area, which may lead to an abnormal buildup of lymph nodes that can cause swelling. Lymphedema may cause pain or discomfort in the affected area, and the overlying skin may become thickened or hard. The risk of lymphedema increases with the number of lymph nodes removed. There is less risk with the removal of only the sentinel lymph node. In case of extensive lymph node removal in an armpit or groin, the swelling may affect an entire arm or leg. In addition, there is an increased risk of infection in the affected area or limb. Very rarely, chronic lymphedema due to extensive lymph node removal may cause a cancer of the lymphatic vessels called lymphangiosarcoma. Seroma, or a mass or lump caused by the buildup of lymph fluid at the site of surgery. Numbness, tingling, swelling, bruising, or pain at the site of the surgery, and an increased risk of infection. Difficulty moving the affected body parts, skin or allergic reactions to the blue dye used in SNLB. A false negative biopsy result, that is, cancer cells are not seen in the sentinel lymph nodes, even though they have already spread to a regional lymph nodes or other parts of the body. A false negative biopsy result gives the patient and the doctor a false sense of security about the extent of cancers in the patient's body. Is SLNB used to help stage all types of cancer? No. SLNB is most commonly used to help stage breast cancer and melanoma. It is sometimes used to stage spinal cancer 1 and endometrial cancer 2. However, it is being studied with other cancer types, including vulvar and cervical cancers 3, and colorectal, gastric, esophageal, head and neck, thyroid, and non-small cell lung cancers 4. Right, so what are the possible harms of SLNB? All surgery to remove lymph nodes, including SLNB, can have harmful side effects, although removal of fewer lymph nodes is usually associated with fewer side effects, particularly serious ones such as lymphedema. The potential side effects include lymphedema or tissue swelling during lymph node surgery, lymph vessels leading to and from the sentinel node or group of nodes are cut. This disrupts the normal flow of lymph through the affected area, which may lead to an abnormal buildup of lymph fluid that can cause swelling. Lymphedema may cause pain or discomfort in the affected area, and the overlying skin may become thickened or hard. The risk of lymphedema increases with the number of lymph nodes removed. There is less risk with the removal of only the sentinel lymph node in case of extensive lymph node removal in an armpit or groin. The swelling may affect an entire arm or leg. In addition, there is an increased risk of infection in the affected area or limb. Very rarely, chronic lymphedema due to extensive lymph node removal may cause a cancer of the lymphatic vessels called a lymphangiosarcoma. Seroma, or a mass or lump caused by the buildup of lymph fluid at the site of the surgery. Numbness, tingling, swelling, bruising, or pain at the site of the surgery, and an increased risk of infection. Difficulty moving the affected body parts, skin or allergic reactions to blue dye used in SNLB. A false negative biopsy result that is cancer cell. Cancer cells are not seen in the sentinel lymph node, even though they have already spread to the regional lymph nodes or other parts of the body. A false negative biopsy result gives the patient and the doctor a false sense of security about the extent of cancer in the patient's body. About the extent of cancer in the patient's body. Is SLNB used to help stages of all types of cancer? No. SLNB is most commonly used to help stage breast cancer and melanoma. It is sometimes used to stage penile cancer and endometrial cancer. However, it is being studied with other cancer types, including vulvar and cervical cancers, colorectal, gastric, esophageal, head and neck, thyroid, and non-small cell lung cancers. That was just a repetition, but it's for those who are yet to understand or yet to comprehend what's this about. So read step-by-step details and you should be in good stead. What has research shown about the use of SLNB in breast cancer? Breast cancer cells are most likely to spread first to lymph nodes located in the axilla or armpit area next to the affected breast. However, in breast cancers close to the center of the chest near the breastbone, cancer cells may spread first to lymph nodes inside the chest under the breastbone called internal mammary nodes before they can be detected in the axilla. The number of nodes in the axilla varies from person to person. The usual range is between 20 and 40. Historically, all of these axillary lymph nodes were removed in an operation called axillary lymph node dissection, or ALND. In women diagnosed with breast cancer, this was done for two reasons: to help stage the breast cancer and to help prevent a regional recurrence of the disease. Regional recurrence of breast cancer occurs when breast cancer cells that have migrated to nearby lymph nodes give rise to a new tumor. Please take a screenshot of this and study on it. Sentinel lymph nodes, right? Biopsy of the breast, radioactive substance, and or blue dye is injected near the tumor. Just a repeat of the theoretic part of it, showing you the illustration. The injected material is located visually and with a device that detects radioactivity, the middle panel here, the middle one. Right, the sentinel node, the first lymph nodes to take up the material is or are removed and checked for cancer cells in the last panel here. Right. Also credit to Therese Winslow. Thank you. However, because removing multiple lymph nodes at the same time increases the risk of harmful side effects, clinical trials were launched to investigate whether just the sentinel lymph nodes could be removed. Two NCI-sponsored randomized phase 3 clinical trials have shown that SLNB and without ALND is sufficient for staging breast cancer and for preventing regional recurrence in women. And, for preventing regional recurrence in women who have no clinical signs of axillary lymph node metastasis, such as a lump or swelling in the armpit that may cause discomfort, and who are treated with surgery, adjuvant systemic therapy, and radiation therapy. Well, this is details of a trial that's been done there. I'll just read it out for you. One trial involving about 5,611 women, researchers randomly assigned participants to receive just SLNB or SLNB plus ALND after surgery 5. Those women in the two groups whose sentinel lymph nodes were negative for cancer, a total of 3,989 women, were then followed for an average of 8 years. Their research has found no differences in overall survival or disease-free survival between the two groups of women. I repeat, the research has found no difference in overall survival or disease-free survival between the two groups of women. Another trial, which included 891 women and tumors up to 5 centimeters in the breast, 1 or 2 positive sentinel lymph nodes. Patients were randomly assigned to receive SLNB only or to receive ALND after SLNB 6. All of the women were treated with and lymph is filtered through lymph nodes, which are found widely throughout the body and are connected to one another by lymph vessels. Groups of lymph nodes are located in the neck, underarms, chest, abdomen, and groin. The lymph nodes contain white blood cells, B lymphocytes, T lymphocytes, and other types of immune cells. Lymph nodes trap bacteria and viruses, as well as some damaged and abnormal cells, helping the immune system fight diseases. Many types of cancer spread through the lymphatic system, and one of the earliest sites of spread of these cancers is nearby lymph nodes. What is a sentinel lymph node? I think we've just read through all that. Now, what has research shown about the use of SLNB in breast cancer? Breast cancer cells are most likely to spread first to lymph nodes located in the axilla or armpit next to the affected breast. However, in breast cancers close to the center of the chest near the breastbone, cancer cells may spread first to the lymph nodes inside the chest under the breastbone, called internal mammary nodes, before they can be detected in the axilla. The number of lymph nodes in the axilla varies from person to person. That will be also discussed. So what has research shown about the use of SLNB in melanoma? It indicates that patients with melanoma who have undergone SLNB and whose sentinel lymph node is found to be negative for cancer and who have no clinical signs that cancer has spread to other lymph nodes can be spared more extensive lymph node surgery at the time of primary tumor removal. A meta-analysis of 71 studies with data from 25,240 patients found that the risk of range lymph node recurrence in patients with a negative SLNB was 5% or less. The diagram shows the sentinel lymph node biopsy in a patient with melanoma, a radioactive substance, and or blue dye. The injected material is located visually and or with a device in the middle panel in the central mode. First, lymph nodes take up material, it's removed and checked for cancer, and the last panel. So these are the three, right? Lymph node, radioactive substance, tumor, sentinel nodes, probe, sentinel nodes removed. Findings from the multi-center selective lymphadenectomy trial 2 MSLT2 also confirmed the safety of SLNB in people with melanoma with positive sentinel lymph node nodes and no clinical evidence of other lymph node involvement. Right, now these are all the references. Now going back. Now how does a pathologist examine tissue? Tissue or cell specimens must be cut into very thin slices called sections so the pathologist can look at them under a microscope. The specimen must be processed to make it solid before it can be cut into sections. The most common approach for tissue examination involves chemically fixing the specimen, usually with a chemical called formalin. This stabilizes the cells for further processing in an automated machine that submerges tissues in substances that remove water and replace it with molten paraffin wax. Once processed, the tissue is embedded into a permanent paraffin wax block to be cut. The paraffin-embedded tissue is then sliced into very thin sections that are placed on the microscopic slides. Slides are stained with with dyes to help visualize parts of the cell and structure in the tissue. This is known as histologic tissue examination. And then the fixed sections provide the maximum detail of the structures in a tissue sample, and they can be saved and analyzed in the future if needed. Prepared fixed sections normally takes several days. The pathologist typically sends a pathology report to the doctor within 10 days after the biopsy or surgery is performed. Frozen sectioning is another approach used by a pathologist for tissue examination. Frozen sections are prepared when an immediate answer about a tissue sample is needed. For example, this type of examination would be used during surgery to provide the surgeon with rapid diagnosis for an area of abnormal tissue and then the extent of the abnormal area while the patient is in the operating room. So to make frozen sections, the tissue sample is rapidly frozen, cut into sections, using an instrument called a cryostat. Using an instrument called a cryostat, stained and examined by a pathologist. This can be done in about 15 to 20 minutes. So frozen sections are suitable for preparing tissues for some tests such as immunofluorescence and immunohistochemistry. However, the fixed permanent section preserves more details and is more commonly used to make a diagnosis. What is a group description on a surgical pathology report? The gross description includes the color, weight, and the size of a tissue sample as seen by the naked eye. It may also include the shape of the tissue sample and any visible abnormalities. It would indicate the body site from where the tissue was taken, from how many samples were taken, whether and how many lymph nodes were removed. What is a macroscopic description on a surgical pathology report? The microscopic description in a pathology report includes information about the appearance of the cells after they have been stained with our routine stains such as hematoxylin and eosin, also known as H&E, viewed under the microscope. H&E staining helps identify different types of cells and tissues and provides important information about the pattern and shape of cells, right? And structure of the tissue. With H&E staining, hematoxylin shows the ribosomes, chromatin, genetic material within the nucleus, and other structures in the nucleus as deep blue-purple color. Eosin shows the cytoplasm, collagen, connective tissue, and other tissues that surround the supported cell as an orange-pink red color. This description may also include the type and number of cells seen in the tissue sample, how abnormal the cells look, also called the tumor grade, and whether there are notable cell features such as the arrangement and behavior. Microscopic description section will also indicate whether abnormal cells are found in the margins, the edges of the tissue that has been removed by surgery, or lymph nodes. Margins are described as a negative or a clean when the pathologist finds no cancer cells at the edge of the tissue, suggesting all of the cancer has been removed. A margin is described as a positive or involved when the pathologist finds cancer cells at the edge of the tissue, suggesting that some of the cancer has not been removed. Lymph nodes are called positive if they have cancer cells and negative if they do not. So this description may also include the results of additional tests that were performed on the tissue, depending on the cancer type. That include tests that measure the properties of cells in a sample, including the number of cells, percentage of live cells, cell size and shape, and the proportion of cells that have a tumor marker on the cell surface. For this, we need to see the tumor markers, which is already dealt with. Investigate generic or molecular abnormalities in specimens with the use of specific techniques. These include karyotyping and to detect aneuploidy abnormal numbers of chromosomes and large translocations in which long pieces of chromosomes are broken off and moved to other chromosomes, as well as fluorescence in situ hybridization to detect specific chromosomal deletions and translocations. What is the diagnosis on a surgical pathology report? The diagnosis section of a pathology report is the pathologist's summary of all the findings of the visual and macroscopic examination of the tissue specimen, in combination with relevant clinical information. It is in this section that the cancer type will be identified, including the tumor grade, lymph node status, margin status, and stage. Are molecular characteristics of a tumor included on a surgical pathology report? Certain molecular tests, sometimes called biomarker tests, are done as part of the initial pathology analysis for all cases of a given cancer type. For example, a pathology report for a patient with suspected breast cancer will include the results of testing for estrogen and progesterone receptors and the protein HER2 /new. The results of these tests can help identify what treatments are best for individual patients. A liquid biopsy in which sample of blood or other body fluid is tested to look for pieces of DNA that have been released from tumor cells is another way that the molecular characteristics of a tumor may be analyzed. The findings of these additional tests may be provided in separate reports that are linked to the pathology report. Pathology examination is increasingly incorporating analysis of the structure and sequence of DNA extracted from fresh and fixed tissue samples to refine the cancer diagnosis through improved subtyping and stratification of tumor types and to better inform treatment. What other information might be included on a surgical pathology report? In the comment section of the pathology report, the pathologist may note unusual features of the sample, such as information about the cytogenetic and or molecular characteristics of a tumor, or provide additional information. The comment section is often used by pathologists to provide more details about the disease and its diagnosis and to recommend additional tests that might be needed. May include relevant clinical history or test results, abnormal findings that could have changed a typical diagnosis, previous samples or diagnosis for the patient, and other possible diagnoses. It will also mention tests that are still in process, that is pending. How will one find out what's in the surgical pathology report? The doctor in charge of the patient's treatment will tell the patient about the findings. The patient can also discuss their report with the pathologist. The patient should be aware that pathology report results will often appear on the patient's portal at the time the doctor receives them, and which means that the patient may see the report before the doctor has had a chance to review it and discuss it with them. Can individuals get a second opinion on the surgical pathology results? Although the diagnosis of most cancers is straightforward, patients or the doctors may want to get a second opinion from another pathologist. Patients interested in getting a second opinion should talk with their doctor. So that's it about that. And next is about tumor markers as discussed. Next is about how the tumor is graded or described. Systems for describing tumor grade can differ depending on the type of cancer, but most tumors are rated as X, 1, 2, 3, or 4, where X is undermined grade, 1 is low grade, 2 is intermediate grade or moderately differentiated, 3 is poorly differentiated high grade, and 4 is undifferentiated high grade. In grade 1, cells look close to normal, and the more the abnormal the cells look, the higher the grade. Grade 4 tumors look most abnormal. It's grade 1 to grade 4. And about prognosis, we get back to that later. Okay, the next topic will be childhood cancers. A cancer diagnosis is upsetting at any age, but especially so when the patient is a child. It's natural to have many questions, such as, who would treat my child? Will my child get well? What does all this mean for our family? Not all questions have answers, but the information and resources on this page provide a starting point for understanding the basics of childhood cancer. Here we deal with the following topics: types of cancer in children, treating childhood cancer, where children with cancer are treated, coping with cancer, survivorship, causing of childhood cancer, and research. Right, so we go for types of cancer. In the United States, 2024 showed about an estimated 9,620 new cases of cancer among children from birth to 14 years. About 1,040 children are expected to die from the disease. Though cancer deaths rate for this age group have declined by 70% from 70s to the 2020s, cancer remains a leading cause of death from disease among children. Most common types of cancer diagnosed in children aged 0 to 14 years are leukemias, brain and other nervous system, CNS tumors and lymphomas. NCI's cancer stat facts include detailed cancer rate and trend information for certain types of childhood cancer. Treating childhood cancer. Children's cancers are not always treated like adult cancers. Pediatric oncology is a medical specialty focused on the care of children with cancer. It's important to know that this expertise exists and there are ever effective treatments for many childhood cancers. So for treatment considerations for children with cancer, we have a video here by the National Cancer Institute, treatment considerations for children with cancer. Please watch.